Welcome to the Owens Recovery Science Podcast, where we dive deep into all things blood flow restriction training. I'm your show host, Johnny Owens, and whether you're a clinician, researcher, or athlete, you've come to the right place. Each episode, we break down the latest research, interview leading experts, and translate complex science into practical applications. We're here to bridge the gap between laboratory findings and real-world implementation. Welcome back to another Owens Recovery Science Podcast. I'm your host, Johnny Owens, with the beard everyone fears, Kyle Kimbrell, my co-host. What's up, Kyle?
Good morning, at least for me.
Yeah, good morning. Our guest today, it's good afternoon for him, and so I'm going to jump right into this. I don't want to do way too much banter because I value his time. But this is someone we've been wanting to get on for quite some time because we're continuing, I guess, Kyle, our guests on our podcast that are way freaking smarter than us.
That's true.
Dr. Feely just kind of blew
Although I don't know, that bar is real high.
Yeah, it's a low bar, but it's again reading his CV today, and it's like, Jesus Christ, what have I done in my life? Nothing. Yeah. So this paper that they recently put out on BFR and diabetes is fantastic. Everyone should read it. And if you don't understand a lot of the language in there, like I don't, it has amazing graphics.
I really loved the way they just built the paper out, like the resources so cool for it. And yeah, it was really great.
Well, and I think, okay, I'm going to do this fast story, Dominic.
I know what story's coming. This is a great story, Dominic. So, you got Johnny in trouble in a roundabout way.
I almost got arrested.
It's hysterical.
I love this paper so much. I've presented it already, not just your paper, but I've included it in some of my talks, in 3 conference talks already this year. And one was for a vascular group, which makes sense. But another, this is why I think it's so translational, and what you do is very translational. We'll get into that. But I presented it to the Orthopedic Foot and Ankle Society, and I presented it to the NFL medical meetings. So apparently I've got a guy crush on this paper, Dom. And so anyways, at the vascular one, I just wanted to point out, like, this is in Cell Metabolism, which it's a big boy journal. It's an impact factor of 31. And you're hitting a group that BFR, I think you have the highest impact factor published BFR paper now. And this is a different group of people that'll see this. So that exposure is really cool. A physical therapy journal, our best one, the impact factor is 3.5. But it's a much smaller group. We're not as big, and it's a different kind of research. But I just put it out. Look, this is 31. We're 3.5. I think this is something we should all pay attention to. This old dude got so mad at the conference that he's never been so offended that I was belittling a physical therapy journal. And he huffed off and was waiting for me in the hallway. And so I'm going to be careful. But I do stand by my guns. It's different journals, but oh my God, it's a big paper. And so
you have to be a little self-reflective at some point, do you not?
Yeah.
Our literature in the physical therapy world, I'm going to be straightforward. It's dog shit.
Oh,
it's not good.
All of it, Kyle. Come on, man.
It's not good.
You get more people mad at me.
That's fine. People can get mad all they want as long as they learn and they get better, but it's just not good. And that's okay. Like, that doesn't mean you're a terrible person because the literature for your profession is awful. It's just like, can we at least recognize it and speak it, and then let's start to make it better, which is ultimately where you're going with that. It's like, hey, there's a bar that we can start to get over, just like Dominik comes on here and makes us feel
and
like
he also got mad because I pointed out cigarettes are bad, and he
come on, like, what are we getting mad about here?
All right, so let's get into this. So today we have Dr. Dominik Pesta. He's out of Germany. He is a exercise physiologist, metabolism researcher, and I really want him to get into his arc. But he does. He's a professor of translational metabolism at the University of Cologne. He's also head of the Metabolism and Human Performance Department at the German Aerospace Center. He's a principal investigator with CECAD, which he can get into as well. And then also he has longstanding ties and does research, and I'm sure I'm butchering a lot of this, with the German Diabetes Center. But what's really cool, the through line through a lot of this is aging and mitochondria. And I think we're all going to get learned up. And so this is our second mitochondria podcast in like a month. So Dominik, welcome, man.
Yeah, thanks for having me. Really, really good that we managed to come together and chat a little bit. Yeah, very cool.
Yeah. So give us your background, what got you into doing this, and all the way from the mitochondria to diabetes and how you can tie that into space and everything else.
Yeah, when I basically I'm an exercise physiologist by training, and back then I was interested already from the beginning in biological mechanisms, and that's why my second qualification is molecular biology, and as I said, I had an initial interest in understanding training adaptations. And back in Innsbruck, where I used to study, we were very interested in altitude training, due to the mountains, for example. So that was some initial work that we did with training adaptations in hypoxia and normoxia. And during my further research, I got interested in the metabolism field, and especially during my postdoctoral work, I got interested in metabolic diseases and how to possibly prevent them. And that continued into a particular interest in lifestyle interventions, and in particular exercise training and what that can contribute to preventing and managing metabolic diseases such as type 2 diabetes. And here we were always looking for, the classical adaptations and classical mechanisms mediated by endurance training, by resistance training, are quite well known. And we wanted to get into this innovative training modalities that you have. And of course, blood flow restricted training, BFR, is not it's not new. It has been around for many years, but it hasn't never been really applied to this patient group that we did then. And we have the people with type 2 diabetes in the focus. Those are individuals that have limited capacities, that have a different musculature compared to healthy people, that have deficiencies in the muscle energy metabolism, mitochondria you touched upon. And that is what really got us interested. And, it has been tested, or the method is established in athletes who can really tolerate things very well. And we were really trying to find, can we apply this to this patient group? And that was the initial challenge. What we said when we set out to start this.
So tie this into your space research. So is that an analogous model of what happens to an astronaut is similar to what you see as an older comorbid patient?
Yeah, it's a good question, and this is actually what I'm very interested now to really bring these facts together. And there is many parallels, I would say, between patients with metabolic diseases and astronauts. I would almost argue that metabolic disease, a terrestrial metabolic disease, can serve as a kind of a surrogate model, or as a model for an astronaut's adaptations. And this includes parallels on many levels. For us, of course, it's the skeletal muscle that is most important. People with type 2 diabetes, they will have changes in the musculature, including fat infiltration, for example, due to the caloric surplus that they are exposed to. and in combination with their metabolic disturbances, which will induce also dysfunction at the mitochondrial level, for example. So these energy, these powerhouses, the energy powerhouses of the cell that are producing all the ATP, they are not so happy with that environment, and they get they get a little bit dysfunctional, and in the end that is quite similar to adaptations that you would see in space. I mean, space research is hard to do because you don't have access to all the tissues that they can obtain in humans in studies on the Earth. But we see that those astronauts also have dysfunctional mitochondria, for example, and of course they have all the parallels in muscle disuse, atrophy, and those things that you can also find. The decreased muscle quality, like power output per muscle per lean mass, if you wish. Those things, there's many parallels, including, of course, also the systemic metabolism. They will have changes in the liver metabolism. They will have changes in insulin sensitivity that are there's a lot of parallels.
Yeah, it's pretty interesting. I saw one of your bios, it's nothing ages you like being an astronaut, it sounds like, which is pretty wild. When we're really looking at these long haul flights and, being on.
Yeah, it's true. And, in the end, it's one of the goals is, or one of the ideas is also to bring this method more into the realm of the spaceflight, because you have many. There is many really good applications where you can make use of that in the spaceflight context, and we all aware of the decreased intensity that you need with the BFRT, and in space you're very much limited with regard to the weight that you can bring up. So the bulky machinery and heavy loads, it's prohibitively expensive. So that's, for example, one aspect where this comes in very handy, and there is aspects of fluid shifts that astronauts experience. As soon as you're in weightlessness, you have a fluid shift towards the head, and that causes many problems, including eye problems to the eyesight, and astronauts may not be able to fulfill their mission tasks, for example. So NASA and other space agencies are very much interested in preventing this or trying to find countermeasures to this headward fluid shift. And one that we and others have worked on is this lower body negative pressure, that you apply some kind of pressure to the lower legs, try to pool the blood in the lower legs and prevent this fluid shift. And in the end, that's what BFRT does, which could become very handy, for example, for astronauts.
And throw some exercise on it. It's wild because we got our first space-rated Delphi unit, so one has gone up on SpaceX, but when we were there at NASA, some of the astronauts on the space station we were able to see some video with them, and it is wild how big their heads were from the fluid shift, and they look like Kyle's head. It's crazy how swollen and big. So,
for me, it's the steroids.
It's right. Yeah. Getting into mitochondria, because I really want to learn from you. Some of our audience members might not be super versed in everything about mitochondria, but another thing that I really don't understand is for a paper like this that we're going to get into, how do you measure things that are changing, like more mitochondria, oxidation and things like that? And there's, I was reading this Innsbruck style of doing, it's like, this is the gold standard and the best. And, you train there and trained at Yale. I don't know. Do you know Brian Irving?
Yes, I know.
Yeah. So years ago when you and I first kind of started talking, and I told Brian, hey, there's this mitochondria guy in Europe. I didn't say Germany, that's looking at doing a BFR study. And he's apparently one of the big dogs over there. And Brian right away said, oh, Dom Pesta, right? So apparently the way you do it is cool. Right. So if you don't mind going into all that for me.
No, for sure. Yeah, Brian is a good friend, and I met him a year ago in Innsbruck, and we discussed mito stuff. So how to assess, how to measure mito function? It's a good question. There are several ways, but I want to focus on the approach we use, and in the end, what we are doing is we are able to maintain minimal invasively with some needle biopsies. We're able to take some muscle sample, milligrams. It's like your fingernail, really milligrams, and we are able to take this. And we also, in that study, we also took biopsies from the belly fat, from the subcutaneous fat, and then you have your tissue. And basically, you have your beautiful muscle fibers under the microscope. You see that, and you treat them a little bit. You prepare them, and we permeabilize them in a sense that we make them accessible to substrates. Because then what we do is we put them in our machine, and we provide them with a cocktail that reconstitutes the energetic state that they have in the muscle, if you wish. And we can then manipulate this system by feeding them with different substrates. And mitochondria you may have heard, different complexes where they operate transferring electrons, and this electron gradient, or this electron transfer creates a proton gradient, and the proton gradient is used by the complex 5 or ATP synthase to produce ATP. And that's the energy currency of the cell. So that's the very complex process. But in the end, you get by combusting the foodstuff, you get your ATP, and we can manipulate and feed them with different substrates, and then really get an idea on how the mitochondria operate and operate on different substrates, and how much basically what we measure is the oxygen consumption and how much oxygen they consume. And the better the state of the mitochondria, the fitter the mitochondria are, if you wish, the higher the oxygen consumption rates, for example, are. And then there is other aspects such as how leaky those mitochondria are, so how much protons slip without contributing to energy provision. And this, for example, is suboptimal if you have a high leak respiration. So you try to really get a good balance, and basically with that, and you can also feed them fatty acids, for example, to get an idea about fatty acid metabolism and stuff like that. So with that system, you get a good idea of mitochondrial function. And then we have basically quite simple enzymatic assays where you can test different enzymes that are exclusive to the mitochondria, for example, such as citrate synthase. It's an enzyme that only is located in the mitochondria. If you analyze the capacity of that enzyme, you get an idea of the content, so how many mitochondria you have in the muscle sample. And this is also important.
You're not manually just counting each mitochondria.
you could of course with the microscopy methods you can do that, but we measure the enzyme, and we have an estimate of mito content. So then we have some molecular factors that are involved in mitochondrial biogenesis that we can also assess, and we can say, is there a signal in the muscle cell to pump up or to ramp up the mitochondrial production of new mitochondria and stuff like that. So with that, you get a good idea of what's happening to the mitochondria in your muscle with the training.
Dom's PhD student, and instead of running the citrate synthase, he just makes you go count the mitochondria
when he's in trouble.
Because you were acting up.
Today you're counting mitochondria.
Today you're counting mitochondria.
Yeah, so that's amazing. So, with really good validity, you're able to see how well the mitochondria are working, as well as are we getting more, and that's going to kind of lead into this paper. And so, muscles, energy, expensive, so it has a lot of mitochondria, which is good for the work you do. And so, as you're a diabetic who has poor muscle, they also have poor mitochondria, I guess.
Yeah, exactly.
Is it both? They have less, and they also just don't work as well because of...
So we have looked into that now in detail. If you always have to, if you compare how the situation is in people with type 2 diabetes, you have to match a group of healthy people to really tell, because mitochondria are affected by age. So as we age, they don't get better. They do get worse mitofunction. They are affected by by activity. So of course, if the healthy people train more or walk more or do more exercise, that's a bias. So we really have to see, and they are affected by body composition. So if you're obese, that is also impacting. So we really try to match, and you see that the biggest part is explained by mitochondria. So they simply have less, even if you match for those confounders, they have less mitochondria. But there is also some qualitative differences. So they are not as good, they are not able to optimally function as properly as in healthy people. Yeah, that's exactly, that's the situation that you have, and it's very interesting what you see in the muscle. We see that in people with diabetes, the mitofunction in the muscle correlates well with, for example, disease duration. So in the end, if you have people with type 2 diabetes, the longer they have their disease, the less well their mito will function. So there's a negative correlation with that. And also it correlates with this glycemic control. So their fasting glucose or this HbA1c value, if they are high, their mitochondrial power in the muscle will be lower. So there's very interesting correlations with that. So that is always the idea that there may be some interconnections between the disease and the mitochondrial function.
So when you were looking to do a study and looking at BFR, I'm sure there's a lot of factors that you were considering, but you think the metabolic stress would be the big driver for mito, or the hypoxia, all the above? What were the kind of mechanisms you think that would set you up to have a win?
It's a good question. I assume that it may simply be the metabolic stress and the ischemia reperfusion that you induce that may create. You may also have higher lactate values, in that compartment. Lactate is a very important signaling molecule. It has been recognized. So for oxidative metabolism. So those factors probably will hit the run button for inducing this oxidative phenotype. And for us, it's really interesting, and I think it's very nice to see that this training modality on the one side induces very strong hypertrophic gains and also strength gains, but at the same time induces such an oxidative gain with regard to mitochondrial function that you normally mainly see with endurance training. And I think that's the beauty also in that patient group. That you can basically have best of both worlds if you wish.
You can both.
That I think is interesting.
Yeah. And I don't know if you know Jamie Burr, but they have a multi-center diabetes trial where they're going to be doing walking with BFR. So just endurance that they just started up. So let's get into the paper then. Can you break us down on what the study was and kind of the methods and?
Yeah, so we started out, with it's basically a parallel group design that we used. We compared classical resistance training in the range of 70% one repetition maximum against another group who used the BFR training with 30% of their one repetition maximum. And we did 10 and 10, and
yeah, we'll point out you started this, and then a pandemic hit. So
exactly,
that didn't help.
No, good that you mentioned that. And it was, it was my PhD student at the time, Nina Trinks.
Yeah, I talked a lot with Nina back then.
Yeah, exactly. You remember? Yeah. Who was really at the driving force for that? And as you say, these training studies, they are it's a lot of effort. The people come in 3 times a week to our center in Düsseldorf, and they trained under full supervision all the time. And they did that for 12 weeks with extensive pre and post testing and so on and so forth. You need to motivate them. You need to explain the training to them and so on. So it's a whole effort. And then this epidemic hit, and we were, all of a sudden, no one could enter the center. It was stopped. We had people, training for 8, 9, 10 weeks that were almost finished, and then they say you stop. So we couldn't use those data.
Brutal.
and yeah, all those things. So a lot of effort, and I think, I don't know, there was a quite a long break where we couldn't test anybody, and couldn't train anybody, and then it was, we could train one person in the room. Normally we had, I don't know, 3 or 4 people working in parallel. So again, when this study then runs forever if you do that. Yeah, and slowly, as we all know, it came back to normal. We trained with masks and so on, and
which isn't fun either.
And yeah, exactly, yeah. So, but then Nina carried it through, and with a lot of effort, we had the 10 and 10. We always had men and women in the both groups, and we did, really try to get a general understanding of what happens with that training method. So we did extensive phenotyping. We did body composition with magnetic resonance imaging, where you can really scan the whole body. We did the strength testing. We did all the glycemic testing with clamps, hyperinsulinic, euglycemic clamps. We did all the blood testing and the muscle biopsy sampling, and we did bicycle testing to get an idea of the oxidative metabolism. So
that's where some people will look at 10 and 10, and when you look at a big RCT, but the things you guys are measuring, you're not going to be able to do 100 patients with that. No, and so these are very valid measures. So we get a lot of just good.
It's a good point. I mean, the sample size is limiting, and one may criticize that. But as you say, there is a lot of deep phenotyping that we do. So I think that's that trade-off. But yeah.
So getting back, just because our audience is really BFR oriented, you landed at it was 60% LOP. Limb occlusion pressure, or trying to be around that, I think. And 3 times a week, it was leg extension and hamstring curl, right? At 30% or 70%. You guys use Delphi cuffs, so you were dialing your BFR in, right? 12 weeks total. And then let's go into what your outcome measures were.
They progressed to, they were assessing along the way.
1 rep max every 2 weeks. Which, so thank God for you, Dominik, and maybe we were able to chime in, but so many studies will do 12 weeks and they do 1 RM at the start and never change it, and then wonder why they didn't see something.
No, that was important for us to really do the training progressively, and I think every 2 to 3 weeks we really reassessed it with reassessed the 1 repetition maximum strength and adjusted the weight, so that they were always training effectively. And also we asked them, with this perceived exertion scale, where are you? You still feel challenged? So I think we managed quite well to really challenge them throughout the 12 weeks.
And no issues with tolerance in this group?
It's with BFRT, it's always discussions about the safety, as you're very well aware of. And I mean, we did a lot of, we did a very thorough screening, of course, prior to including those people. But we didn't have any issues. I mean, the people enjoyed, I would say, both training modalities. Of course, with the BFRT, you always have to, you have to put the cuff around, but therefore you get less training intensity. But it was well tolerated, and we didn't have any adverse events or something like that.
Yeah, and the question we had always a lot of in the days with diabetes was people worried about their vascularity and what the reperfusion and that sort of stuff would do. And we'll get into your paper. You showed there might be something positive for vascularity in this group. But let's just hit on the first note, which is just strength and hypertrophy. What you saw was
So we tested we tested both dimensions, strength, muscle strength and muscle hypertrophy, and we saw about an increase in the quadriceps volume that we did with the magnetic resonance imaging, which is really the gold standard to evaluate muscle volume, and also cross-sectional area. And we, in both groups, we saw an increase of about 4 to 5%. after 12 weeks. And then we tested their leg extension and leg flexion strength, and that increased by about 25 to 30%, something like that. So quite an effective increase in muscle strength also. Yeah.
So that's kind of a win for BFR too, that it equaled. No difference between groups. Both got significantly better high load training. So that's, I mean, if you can say you got to both those with a lower load, that's great.
That was a 1 rep max test, right?
No, it was actually a sub-max leg extension test.
Oh, sub-max.
So we, it's always you have to be careful with people who may not be capable of those high loads. So we did a 3 or 5 rep test throughout, and then we did a test to really evaluate their power or their strength at the end. Yeah.
So let's get into the mitochondria. What do you?
Yeah, and then we looked at mitofunction both in skeletal muscle and in fat tissue. In skeletal muscle, we really found quite major changes. Exclusively in the BFRT group, we found increased respiration or mitochondrial capacity, oxidative capacity, if you wish, both in this complex 1 and complex 1 and 2, or OXPHOS, basically what you say. And then as we talked about the mito content, that increased by about 109%, also only in the BFRT group. And we also tested this, basically the ADP sensitivity, which actually, where we also found very interesting changes. We basically see a decrease in the ADP sensitivity with the training, which may sound counterintuitive, but it's actually an interesting adaptation that you also see in response to endurance exercise training, for example. So what it does, if you break down ATP during contractions, you have the ADP that really stimulates then your mitochondrial function and your further energy production. And in order for the muscle to gain more metabolic control, you decrease the sensitivity so that you have more scope to respond to those metabolic changes. And it gives by increasing the absolute capacity, which we saw, it gives the muscle more control.
Yeah, it makes total sense. Were you expecting to see this big of a difference between groups? Like it was like, well, I thought high load would do something.
I agree. I mean, we have had, or we looked at that earlier, and we saw some adaptations with classical resistance training also. But in that regard, we didn't, and I was also a little bit surprised that we didn't really see anything in the classical group. Yeah, that's true.
Moving from mitochondria, then you looked at the angiogenic response or potential changes on vascularity.
Yeah, this was some interesting analysis that we did. We basically looked at the transcriptional response to BFRT and the classical training. So basically, what transcriptional programs the muscle switches on and promotes with that kind of training. And here we really saw that the first result is that differentially regulated genes. So basically what genes are upregulated or downregulated, we saw more in the BFRT group that are up or downregulated. But then that doesn't really tell you a lot. You have to look at the pathways that these genes correspond to. And here we really found that these pathways were related to angiogenesis and transcriptional programs inducing vascular remodeling, which I think fits quite well with the concept that the BFRT does in the end, causing ischemia, reperfusion, and metabolic stress. And the body really tries to adapt to that by increasing its vascular angiogenesis program.
And it was, I think it was like 100 genes in the BFR group versus like 10 in the high load group. Yeah. You have this little volcano plot on there, which I stole in my talk, which is so cool because it's just like, wow, this one's exploding and the other one's kind of just a little sputter. But I mean, like just going along when I was reading this paper, just the muscle hypertrophy and strength would have been like, wow, that's badass. And then it's like the mitochondrial piece. It's like, whoa, that's even crazier. These diabetics need that. And then, what a diabetic really, really also needs is better angiogenesis and improving that vascularity. And then that looks like there's potential, and it's like, holy crap. And then the one I want to work on is looking at visceral fat.
Mm-hmm. Yeah, no.
I read the paper. I was like, I need to start doing BFR more again.
No, that was a very nice and kind of, you know, a little bit unexpected finding. We also, of course, looked at body composition changes, and for us, it's important to look at the fat compartments. And the most important fat compartment for your health is the visceral fat, and it's basically the belly fat that drains in your portal vein of the liver. And if that is in the visceral fat is dysfunctional or accumulates in metabolic diseases, you have all pro-inflammatory cytokines and fatty acids that are really draining into the portal vein and go to the liver, and then in the end may cause fatty liver or impair liver health, so to say. So that's really key to keep that at bay. And we saw in the BFRT group that the visceral fat was reduced, the volume of the visceral fat was reduced after training, and we only saw that in that group. And I think that's very beneficial, basically, and a very beneficial adaptation for this patient group.
Yeah, and so mechanistically, did you have an idea, like after you read that, of like, oh, I know it was this lipolysis or?
Yeah, so I think, you know, in the end, it may, we didn't really specifically, so we don't have an answer to that yet, but it is very likely related to the strong systemic, or actually the strong local response that may also create a systemic response and induce hormonal changes, releasing catecholamines and growth hormones and stuff like that. So the endocrine response may be elevated. And that causes a higher lipolytic potential, and then of course you have that receptor density that is very high in the visceral compartment, and that can melt then the fat. But you have to have the endocrine response, and that is happening with the BFRT.
That was very cool to see. I think that's the first time that's been documented as well. Looking at insulin sensitivity, that didn't change. Can you kind of go down of why you think?
Yeah, it's a good question, and we really we are a diabetes center, so that was of course an important endpoint for us, and it was kind of disappointing, to be honest. And we really looked up and down. We tested basically all parameters that you can imagine. We did these clamp tests to assess insulin sensitivity on a whole body level. And we also looked at hepatic insulin sensitivity in the liver and at liver fat and muscle fat and all those fasting glucose and so on. And we really didn't see any changes. And it's difficult to pinpoint. My guess is that in these 12 weeks in both groups, although we see muscle gains, they may still be moderate. And it may be that the time frame, of the 12 weeks, training studies are always a pain. Either they are too short and the longer they are, the more effort it is. So that's why they are all in the short range, probably. That's why we probably didn't catch that. And I mean, I was a little bit surprised actually to see nothing on the muscle level, because we also, and that's interesting, we also tested intramuscular fat. So basically the fat that is within the muscle, and that decreased by about 10%, which is also very, very nice to see, because people tend to have more fat in their muscle. So that melted away in both groups. But it's probably on a scale that's borderline, not enough to induce.
Do you think it would have been
changes.
something if you just retested further down the line, like they've got all this new mitochondria and maybe the muscles just getting better adaptation, that if 6 months later you would see insulin sensitivity type stuff change?
I would assume so. I mean, if they would have continued, I would really assume that you may see something down the line. And in the end, it depends. There is so many different outcomes, and it's just one. It's important though, but it, if you're happy, if you're more independent, if you're stronger, that's also a gain. That's worth it.
Well, increasing muscle mass and strength, increasing mitochondria, big time, increasing the potential angiogenesis, big time, reducing visceral fat. Freaking sign me up, bro.
It's a pretty good sell.
And see why it made it into cell metabolism. So do you have a next step? I mean, you're probably like, I'm never doing another training study again.
Yeah, I mean, now as I'm here at the, I mean, of course, there is so many different potential applications. One I would really be interested to test is people with metabolic diseases and with complications. They have the longer you have this disease, you have different side effects, renal side effects, or nephropathy, neuropathy, those things, and it would be very valuable to test this method in these individuals, because it's difficult for them to train. They are limited by their training options. So I think it's worthwhile to explore this. Can they benefit from this modality? And then the other idea is, of course, as I'm now at the Aerospace Center, to really go into applications for spaceflight and test it for, not only for spaceflight, but also for lunar missions, for Mars habitats, where people are in reduced gravity, and if the idea of a lunar base, 1/6 of the gravity of Earth, you need to find very good training opportunities. It's not so easy, but you need to keep the people fit if they live up there.
One thing I found really kind of interesting, Dom, as I was reading the paper, is there's so many different things y'all were able to look at, like at the muscle level, from various different things like HIF1A, PGC1 alpha, all of that stuff. And in looking at some of the results, I thought it was interesting. Some things like HIF1A and mTOR didn't really change in either group, which I thought was in myostatin, I think, was another one that didn't seem to really change. And those are typically things we kind of assign to, like muscle that's adapting, changing, getting bigger, that sort of thing. So it just made me wonder, are we potentially kind of moving down a path with all these different things that you're able to measure, of ultimately maybe an ability to do like a simple biopsy test and then really kind of refine the exercise prescription that we might give people? Because it seems like, maybe in these scenarios where muscle is kind of sick, if you will, which could be an astronaut, could be diabetic, could be after an ACL injury, all these different kind of scenarios that you might kind of think up that we deal with clinically. If we were able to better kind of evaluate the status of muscle and know what types of stimulus it would respond to, it seems like that would be like a really good thing. So I was just kind of curious your thoughts on that front, and if we're headed that way, if or not.
No, a very good point. In the end, that's the precision medicine approach, or personalized medicine approach, and you're absolutely right. I mean, we have, although it's still challenging, we have methods to really very finely look at different adaptations, and in the end, although, as I said, we just tested a few patients, but I think it's a very valuable step and piece in defining basically a biological program in response to a training stimulus, and by knowing really the portfolio of changes that are induced by these specific training methods, you may be able to then really tailor what is wrong with that person, or what disease, what are the specific features of that disease, and which training stimulus best, ameliorates and helps with that disease.
I started reading this and I was thinking, gosh, I really wish someone would go just like serially kind of biopsy the quad, even just like right after an ACL injury, and just kind of track that like month after month, just so you have like a profile of like, what is this muscle looking like sort of all along the way. Because like, for example, I have colleagues who treat a lot of ACL injuries, and they will describe a point at which in the post-operative rehab phase, they just get to a place where it feels like the muscle stalls, like it just kind of stops responding, and I'm like, well, what is happening there? Is there just a different type of stimulus that muscle needs? Is the body somehow holding back the adaptation in a protective fashion? Seems like it'd be really useful to be able to kind of take a biopsy, look at it, and then say, okay, here's how we need to modify your program to keep you kind of moving forward, if you will.
Yeah, I mean it goes along, aware of the anabolic resistance that you're getting when you age, for example. It's also, people will not respond as efficiently to anabolic stimuli. So, yeah,
a lot of factors too, nutrition and
for sure,
yeah,
sleep and a billion things. But yeah, that would be badass. Well, Dominik, we appreciate your time. This is amazing stuff. I hope you guys are able to do some more BFR research. Keep it going, man. I know this kind of research is a pain in the ass, but I'm excited. I know Luke Hughes. Do you and Luke collaborate?
Yes. I know him. Yeah. We are in touch. We share some ideas or discussing ideas of really pinpointing something and get something going. Yeah. Together.
We always link up at the NASA shop conference.
Okay.
Yeah, you should come next year. I'll buy you a beer and barbecue.
Sounds
and
good.
Luke will take you to Chick-fil-A.
I'm curious. No, thanks for having me. It was really great to chat, and I hope I could break it down a little bit and make it understood for.
It was amazing stuff.
That was awesome.
Appreciate you, man. I guess most important point is Germany going to win the World Cup.
We'll see.
We'll see. All right.
They're looking good.
They're good. France looks good. US now we think the US is going to win all of a sudden.
We're getting the rope-a-dope, I'm afraid.
Yeah. All right, Dominik. I appreciate your time, buddy.
Thank you very much for having me.
Yeah.
Thanks. Thanks for tuning in to the Owens Recovery Science Podcast. Before we go, a quick reminder that the information discussed on this show is for educational purposes only and is not intended as medical advice. Always consult with your healthcare provider before making any changes to your treatment or training regimen. For show notes and additional resources, be sure to check out owensrecoveryscience.com. And don't forget to like the show and subscribe for more evidence-based insights. Until next time, earn your deflate.